Good afternoon, everybody. Welcome to the next in our series of the Canadian Health Workforce Network webinar. I'm just going to share slides. So today we are going to be talking about COVID-19 and the mental health and substance use health workforce. And I'm very pleased to have with us my colleague, Mary Bartram, and Jelena Atanakovich, who are members of the team and will be presenting today. And I'm also very pleased to have Kim Holohan, Gord Gardner, and Bonnie Wong, who are members of our advisory board, to provide some commentary. So I want to first of all start off with a land acknowledgement. And with webinars, we are coming from a variety of different regions. I'm coming to you from Ottawa, the unceded territory of the Algonquin Anishinaabe people. But I do also want to acknowledge that land acknowledgement is only one small part of what I have listed here: disrupting Indigenous erasure and dismantling colonial structures. I encourage everyone to read the Truth and Reconciliation Commission's calls to action. And we at the Canadian Health Workforce Network are taking on one in particular to focus on increasing the complement of Indigenous health workers. And the only way that we will know if we've succeeded with that is to actually count. So we are working with Indigenous health professional associations, following their lead about how it is that we would go about better counting and acknowledging who in the health workforce is Indigenous. So our project is looking at the COVID-19 impacts on the capacity of the mental health and substance use health workforce in Canada. And I'll provide with a little bit of context before I pass over to Jelena. So it's important to look at the side of the capacity to be able to provide services for the increasing population needs. So there have been some immediate impacts of the pandemic on higher rates of mental health symptoms, increased substance use, and it's the greatest impact is where those two intersect. So there has been at the same time a reduction in capacity and a disruption in service delivery. And so that's really, there's also been a significant pivot to virtual care. And so many of the pre-existing, pre-pandemic challenges have been amplified. And so we wanted to shine a light on those longstanding gaps, the inequities, and stigma. And the pandemic has also been compounded by the opioid epidemic, which has continued unabated. So history shows that we should expect impacts that will be delayed, complex, and long-term. And we are pleased to see that in the budget and election 2021, a commitment to develop access standards and expand mental health transfer. And the new Minister of Mental Health and Addiction is a welcome development. There will also be a renewal of the bilateral agreements between the federal government and the provinces and territories in 2022. So our focus for today is the capacity of the mental health and substance use health workforce to respond to these emerging and growing needs. So we'll start first with an overview of the findings. So just to tell you a little bit of background about the project, this was a one-year grant from the Canadian Institute of Health Research through their mental health and substance use operating grant. The overall purpose of our study was to assess the capacity of the full mental health and substance use health workforce across the country to better match emerging population needs with service capacity to prepare for longer-term shifts in service delivery. Even with significant financial investments, mental health and substance use services don't just magically appear. And this is what Mary and I wrote in 2020 before we received the grant. This is a little overview of the project team. So Mary Bartram and I are co-principal investigators. Jelena Atanakovic is one of our co-investigators who will be providing an overview of the literature review. Kate Leslie and Carolyn Chamberlain Rowe are also co-investigators, and we have 4 amazing assistants working with us, both the librarian, Daniel Rice Mishrahi, and Christine Tull, students who are working with us. And we want to acknowledge members of our advisory committee, noted here by their logo. So this has been a very intensive project starting from September 2020 and really concluding in September 2021. We undertook a rapid literature synthesis. We had a webinar to kick things off in November of last year. We launched a survey of mental health and substance use health workers. We started doing the analysis in March. We undertook key informant interviews and had a virtual policy dialogue in June. And then this is our sort of culminating presentation. So with this, I'm going to pass over to Jelena.
Thank you, Ivy. Our rapid literature synthesis included both academic and gray literature that helps answer our research questions. The searches have been performed in CNAL, Medline, and Google Scholar databases using 3 main concepts outlined on the screen here. In his search, a librarian aimed to capture the impact of gender and other social identities on issues we are examining, so that issues such as challenges providing virtual services to racialized populations are captured. A list of inclusion-exclusion criteria has helped guide the search and the selection of the articles for review. Out of 1,519 articles that we screened, 129 were included for extraction. Most of the academic literature we have reviewed is extensionally based. Very few Canadian studies explore the issue of capacity of the MHSU workforce to respond to the increasing needs during the pandemic. Gray literature search has been involved searching the websites of international, national, and provincial associations, regulatory bodies, and advocacy groups, using the same key concepts used for academic literature. 280 gray literature sources were included for extraction. The literature we found has been extracted using these tools that we created according to predetermined categories. So that we actually identified at the outset in order to capture relevant pieces of information. Next slide, please. The findings of our literature review could be sorted according to the following themes: impact of pandemic disasters on MHSUH workforce capacity or service provision, MHSUH workforce capacity responses, impact of gender and other social identities. Some of the articles focused on more than one of these themes. The following slides I will walk you through are dedicated to overview of the findings related to each of these themes. Next slide, please. The literature shows that COVID-19 has had massive impacts on mental health care internationally. Most systems were under-resourced and underprepared, struggling to manage both existing and new clients. Integrated community mental health systems exhibited greater adaptability in contrast to services which depended on face-to-face and hospital-based care. On the right-hand side of this slide, there are some examples of the findings that reflect this specific theme. For instance, a WHO survey shows that pandemic has disrupted or halted critical mental health services in 93% of countries worldwide, while the demand for mental health is increasing. Next slide, please. Most of the literature we reviewed focuses on the strategies employed or that could be employed by MHSUH workforce to modify its service provision in order to better respond to the needs of population during crisis. As you can see on this slide, there is a variety of strategies employed to achieve that. Virtual care is one of the strategies most often discussed in the literature. Some studies explore the advantages and disadvantages associated with this particular approach. For instance, one qualitative US study has identified some challenges related to the transition to telepsychiatry, such as decreased clinical data for assessment, diminished patient privacy, and so on. Many government documents highlight temporary exemptions for prescription of controlled substances. For instance, Health Canada issued temporary exemptions for such prescriptions. Next slide, please. Some papers emphasize the importance of taking into consideration the role that gender, race, ethnicity, and other social identities play in MHSUH service provision and MHSUH workforce capacity responses during COVID-19 crisis. Some scholars and international organizations have been highlighting vulnerabilities among minorities and indigenous groups during the pandemic. It has been noted that COVID-19 exacerbates the already problematic gaps in culturally and linguistically appropriate care. In light of these considerations, some authors, such as Novacek and colleagues, call for racially and culturally sensitive interventions. The quote on the right-hand side of this slide is actually taken from their paper. Similarly, one representative of the government of Northwest Territories emphasizes the importance of specialized programs and argues that the gender-specific programming could be achieved by increasing the number of MHSUH service providers. Next slide, please. While the literature explored in this review sheds some light on the capacity of workforce to respond to increase in MHSUH needs during COVID-19 pandemic, this issue remains largely unexplored, especially in some areas, such as, for instance, the impact of practice setting and service funding models on MHSUH workforce capacity during COVID-19 and mental health of MHSUH workforce during the pandemic, how it relates to capacity. Our review also indicates the need for more research, and especially in some country contexts, such as Canada and UK, studies that compare and contrast the capacity of MHSUH workforce in different countries to respond to emerging needs during COVID-19 pandemic, and research that would focus on the capacity of MHSUH professionals, such as peer support workers or addiction counselors, whose experiences have been understudied, and larger scale surveys that include bigger samples. I will now turn it over to Mary, who will tell you about the findings of our survey and key informant interviews. Thank you.
Thanks very much, Yelena. It's been such a pleasure to work with everyone on the team and with the advisors on this important project. So we had an online survey that was open from March to May, and we're very pleased to see that the survey really opened a window onto the mental health and substance use health workforce, onto service providers that we actually know the least about. So various types of both regulated and unregulated mental health therapists, here used in the broadest sense, but inclusive of clinical counselors, counseling therapists, psychotherapists, and so on, as well as addiction counselors, RSWs, nurses working in mental health, and so on. Next slide, please. So as you see, the majority of our respondents were women, which is not surprising in this workforce. They were Anglophone and middle-aged with an overrepresentation from Ontario, but otherwise good distribution across the country, including in Quebec and in rural and remote communities. And we also had some representation from people who identified as racialized, Indigenous, or living with a disability. Next slide, please. Given the kinds of service providers who participated, it's not surprising to see the strong role of the private sector, and this is a theme I'll pick up throughout my portion of the presentation. So the private sector as both a funder and a practice setting. So on the left, providers could check all sources of funding that apply, and our understanding would be, or interpretation would be, that nearly 3/4 checked off that at least some of their services are paid for with public funding. And this means that 1/4 of respondents get no public funding, so fully in the private sector in terms of financing. On the right, you can see private practice as the top practice setting, followed by community agencies and clinics. And what this reminds us is how important it is to consider how, under our two-tier system, mental health and substance use health services are pretty evenly divided across the public and private sector, with big implications for equitable access. Next slide, please. On average, in the chart on the left, we didn't find much change in hours per week from before to during the pandemic. However, you can see in the histogram on the right that there was a bump in providers putting in more than 40 hours a week. And as expected, you can also see back on the left that massive pivot from face-to-face to virtual service modalities that Yelena spoke of already, from 89% of practice being primarily face-to-face before the pandemic to 64% being primarily virtual during the pandemic. Next slide, please. When we asked people about changes in presenting issues, a few things stood out. First, that there was literally just more of everything during the pandemic. Second, that big increase in financial issues. And third, there were striking increases in substance use, suicidal ideation, and grief and loss. These findings are consistent with just about every poll and survey about the emerging mental health and substance use health needs of the population. And I would also add they're telling in terms of the close relationship between mental health and substance use health that the pandemic has really amplified. Next slide, please. So when we asked people to report overall changes in capacity, we found interesting gender differences, and a great example of why it is so important to apply a sex and gender lens in research. Female providers were more likely to report decrease in capacity and males to report an increase. And while we're not able to go into this much detail, these gender differences did hold by and large across occupational groups. Next slide, please. So when it comes to reasons for the impact on direct services by gender, we see on the left that women were reporting more reasons across the board for the decreases. And on the right, you can see, especially a little bit further down the chart, that men were more likely to have to say that they had the time to volunteer and to take advantage of increased funding. And you might be wondering why my own mental health and substance use concerns aren't rated more highly as a reason for decrease for both men and women. So without minimizing the challenges these providers are facing during the pandemic, from our key informant interviews, we are also wondering and did hear a little bit around how mental health and substance use health providers might be benefiting from having a stronger toolkit for self-care. Alternatively, they may also be pushing through their burnout in an effort to meet the pressing needs of the population. Next slide, please. On this slide, we've unpacked the overall capacity changes by our main provider groups. And as you can see, addiction counselors reported the biggest decreases in capacity, and the biggest increases in capacity were reported by mental health therapists, particularly when regulated. On the next slide, we can see how group and community outreach services were most disrupted, not surprisingly, and also see a theme that I'll pick up again later on, how peer support was really able to maintain continuity of services and even increased its capacity during the pandemic. On the next slide, when we asked people who said they could provide more services, what would make that possible? We see that funding and increased pay tended to be reported by all the occupations, but more so for regulated mental health therapists. RSWs and regulated mental health therapists pointed to the need for additional coping resources and supports, and addiction counselors and nurses focused more on regulation and being able to practice to optimal scope. So another reminder about that there's no one mental health and substance use health workforce, but rather a very diverse mix of occupations with different needs and levels of regulation. So we've run regression analyses, if we could go to the next slide, for those of you who are statistically minded, to see which factors contributed most to increasing capacity, which is to say which factors contribute the most to explaining whether people said that they've increased their ability to provide services during the pandemic. And what we found was that providers who only received private funding were 3 times more likely to report increased capacity than those who only report public funding. We also found that regulated mental health therapists were more likely to report increased capacity than psychologists, which suggests that the privately financed mental health and substance use health workforce, those that practice outside of the Medicare framework, have played a key role in responding to emerging needs during the pandemic. On the next slide, I'll just provide some highlights of the key informant interviews, which we also held as part of the mixed method approach in the study. So a key theme around the intensity of the initial impact, and just a few quotes here, speak to people flipping their whole day onto a computer overnight, how the pandemic drove some staff into early retirement or indeterminate leave, particularly in the acute care and hospital sector, how redeployments were needed to fill gaps, and as I mentioned, how peer support workers were motivated to move very fast to resume service delivery. On the next slide, we show some quotes around the public-private theme. So on the one hand, recognition of the mental health impacts of the COVID-19 pandemic is starting to break down some big walls, though. Certainly we have a long way to go, but simply because the need is there, more provider groups have been able to start getting added to eligibility lists for employment-based benefit programs. Kim will certainly speak more to this later on in terms of the ongoing challenges on that front. There also needs to be some kind of reckoning between the public and private systems to ensure that added capacity on the private side doesn't come at the expense of capacity in the publicly financed system, that there needs to be a net benefit at the population level. On the next slide, as I mentioned earlier, one's own mental health and substance use health concerns didn't come through very strongly as a key reason for reduced capacity. But we did hear from key informants that burnout is an issue. Seeing the need and not being able to meet it, being called on to support colleagues, and opting to leave more positions, more stressful positions in the public sector for roles in the privately financed system. On the next slide, data gaps. So while there are gaps in what we know about many mental health providers, substance use health is at a whole different level. And as this key informant said, it's just a huge chasm. Data silos is another issue. Sometimes the data exists, but it isn't used or isn't available for planning at the service delivery level. And one respondent pointed to the need for a common repository and describes just what it would take to get there. On the next slide, there's some highlights from the policy dialogue that we held in June with over 60 participants. We ran a priority setting process, and participants identified these priorities for action with equity as a cross-cutting theme. And I'll just highlight the top two. Universal public funding. Participants called for full funding for mental health across the country. So fully funded preventive mental health care is needed, including substance use health. And they also called for the gaps in the mental health and substance use health workforce data to be addressed. They called for standardized workforce data to meet the needs of the population. You can't manage what you don't measure or compare across provinces, across provider groups, including demographic data, which will contribute to culturally competent and safe care. So I'll just recap here before turning it back to Ivy and to our awesome panelists. So 4 emerging findings: capacity decreased overall, but more so for women and addiction counselors. That the hidden workforce is playing a really key role, whether peer support, counselors and therapists, or even RSWs. Need is driving recognition by regulators and insurers, but there are risks of shifting capacity between the public and private sector, and also we can't overstate there's still a long way to go in terms of regulation and recognition. And as Jelena discussed, the inequitable impacts of COVID-19 point to the need for targeted and barrier-free services. On the policy side, our findings highlight the importance of a gender equity lens, of better recognizing the needs of this workforce in policy. And what we see again and again is that when people think mental health and workforce, they immediately go to the mental health needs of the physical health care workforce. And of course, these are very acute and definitely warrant prioritization. But if we don't pay some attention to the capacity of the mental health and substance use health workforce that provide those services and supports, how are we going to be able to address the emerging needs of the population? We also see an opportunity to leverage that bit of momentum in regulation and recognition, and the need for that overall picture and plan across mental health and substance use health and across the public and private sector. So thanks very much, and I'll turn it back to Ivy to kick off the panel.
Thank you so much, Mary, for walking through all of those really important findings. What's very clear from doing this research is we've only been able to scratch the surface, and there's so much more work that needs to be done, particularly from a data infrastructure, so that we have more data in this regard. But there's many things that I could say about the project, but I would really like to go next to our panelists. And so we're going to go first to Kim. Please, would you like to go ahead?
Hi everyone, I'm Kim Holohan. I am with the Canadian Counseling and Psychotherapy Association. We are a national professional association with over 10,000 members across the country. Really pleased to be here today. Thank you so much to Mary, Ivy, and Helena for the invitation to take part in the panel discussion. There are 3 topics that I'd like to explore a little further. One is the regulation landscape, specifically as it pertains to mental health therapists, who, and that term, of course, we're using to refer to counselors, clinical counselors, counseling therapists, and psychotherapists. The second topic is around self-care of the mental health provider, and the third is around virtual care. So I'll start with the regulation piece, and we talk about the need to increase capacity within the mental health, substance use health workforce. We know that many providers are at capacity. We also know that mental health therapists have reported that they have the ability to take on more clients. You know, they were the most likely to report increased capacity through the survey. So one of the ways that we can grow capacity within our workforce is to recognize that hidden group, as Mary referred to them, the hidden workforce. So these are mental health therapists who are fully qualified. However, their credentials, whether it is a provincial license for those who are regulated or a professional designation for those who are not, are still not being recognized by all provincial, federal, as well as private funded programs, mental health programs and services and benefits. So I'd like to talk about the two groups, the regulated and the unregulated. I'll start with the regulated. So in Canada, the profession of counseling psychotherapy has been regulated in 5 provinces. So Nova Scotia, New Brunswick, and Prince Edward Island are 3 maritime provinces. They have regulated counseling therapist. Ontario has regulated psychotherapist, and Quebec has regulated those with a psychotherapy permit, referred as psychotherapists. So we have 5 provinces that have regulated the profession. However, in many cases, these individuals are still not deemed as eligible providers by publicly or privately funded programs or employers in the mental health field. So my first policy implication from this research is that this is an untapped resource that we really need to call on all of these individuals, these groups, these programs to please open the doors to these underutilized individuals. The second group is the unregulated group. So in those 5 provinces that have not yet regulated the profession, we do have national and in some cases provincial associations who offer designations that can be used, can be recognized as part of these programs, mental health programs, services, and extended health benefits packages. So again, we've made a lot of progress over the last several years in gaining recognition of both of those groups, both the regulated and the unregulated, who hold a designation. We call it non-statutory regulation. So it's a professional association that performs a self-regulatory role, which is voluntary. So, we find that a big part of this is awareness. Not a lot of insurers, employers are aware of, governments are aware of what is a counselor, a counseling therapist, a psychotherapist, what do they do? How can they contribute to addressing the mental health needs of Canadians? So we call on all of those individuals to recognize this group of professionals. What does this mean if they're not recognized? Well, a couple of things. First of all, we have fewer providers to provide services to those who are in need, and we know that there's a significant increase in needs as a result of the pandemic and those who are requesting services. But secondly, it means that people are paying out of pocket. Clients are still seeing counselors, counseling therapists, psychotherapists, but they are often paying out of pocket. And when we think about the results of this survey, which talked about differences in presenting issues, and the biggest jump, if you remember from Mary's presentation, was in financial needs. So the most significant was that people were experiencing more financial needs as a result of the pandemic, but at the same time, we're expecting them to pay out of pocket to access those services. Regulation itself continues to be a barrier, and we call on the 5 remaining provinces to work with the provincial federations of associations of counseling therapists to implement regulation. Alberta, a couple of years ago, actually passed unanimously in the legislature, the provincial legislature, the regulation of counseling therapy. And we still await proclamation. Proclamation is the final step. So we have a college set up. We have hundreds of counseling therapists who are registered and ready to go. And we await proclamation by government. So, and then the 4 remaining provinces, Newfoundland and Labrador, Manitoba, Saskatchewan, and British Columbia, they're all at various stages of the regulation process. Some have been working on it for over 25 years. Others are a little more recent. So again, we encourage that process to take place. But again, even with regulation, as Mary said, and I will reiterate it again, we can't assume that with regulation comes recognition. That has not been our experience. And you'll see from the data that regulated mental health professionals identified funding, lack of funding as one of the key reasons why they could not take on more clients. So this is really interesting that funding is still an issue, even though they hold a regulated title. So that, I think, explores the concept of regulation, the challenge of the regulatory landscape in Canada. I think part of the issue is, well, awareness I mentioned, but another issue is when it comes to national level programs and services, often there's a reluctance to cover different services across the country. So it's a bit challenging, complicated, I would say, to say, well, in these provinces, we'll recognize this title for counseling psychotherapy, and these will do those. And then in these ones, well, we don't have a regulated title. So which professional designations do we want to recognize? Which ones would stand up next to a regulatory college requiring the same level of education and training, a code of ethics, standards of practice, ethics, complaints, procedure, continuing education requirement, etc. So it's not, I'm not suggesting it's easy by any means, but we're certainly quite actively working with our partners across the country to hopefully make that happen. The next topic I wanted to touch on is the concept of self-care. And we know that the mental health providers and substance use health providers are not immune to the mental health impacts of the pandemic. Although, as Mary shared, we do have folks reporting that they are doing well in terms of their mental health, and that's likely because as professionals who practice in the area of mental health, they have, as Mary said, a self-care toolkit, and probably plow through some of those mental health issues. However, the key informant interviews did talk quite a bit about stress levels going up, morale being down, burnout being an issue, compassion fatigue, of course, as well. We did, and these results do align with a national survey that we conducted, our association, with the Vanier Institute of the Family, as well as the Canadian Association for Marriage and Family Therapy. So we did 2 national surveys, one 3 months into the pandemic, and the second one 1 year into the pandemic. And we wanted to see what was the impact of the pandemic on family therapists themselves in terms of their mental health and well-being, as well as their clients, and what impact it had on their practice. And what we found in both cases, the family therapists, and by the way, family therapists we defined as therapists working with children, adolescents, couples, and or families, they reported they were doing better than the general population in terms of their mental health. And again, that's probably not surprising given their area of expertise and their area of work. However, 1 year into the pandemic, they were not doing as well as they were 3 months into the pandemic. So they reported, for example, their physical health, their exercising, resting, sleeping, practicing self-care, healthy hobbies, healthy projects. It was down in comparison to 3 months in. So again, I think this just speaks to the pandemic taking a toll on everyone, and the importance of us supporting our mental health and substance use health workforce service providers. We have a role, I think, those of us who are part of professional associations, to continue to encourage self-care amongst this group, to provide opportunities for self-care. A key informant interview talked about the importance of supporting our colleagues who have issues, mental health issues, supporting their self-care journeys. So again, from a practice perspective, I think it's really important that we take some time to focus on that. And it did come out of the policy dialogue.
You're on mute, Kim.
Oh, sorry. I think I muted myself there. Virtual care. So there has been, as we know, a significant transition to virtual care at the start of the pandemic. We, in terms of not only the service delivery to clients, but also, or patients, individuals seeking care, but also a transition to virtual service delivery for those who are providing clinical supervision, support to those mental health and substance use health service providers, those who are in training, so students in training to become mental health therapists and other types of mental health service providers. Everyone transitioning to virtual service delivery. I think with, and we've seen this with lockdowns, lifting, restrictions lifting, many are returning to in-person care. However, we know that some will continue to deliver virtual care. So what are some implications of that? We need to look at continued resources that are needed, supports, trainings, service standards. What are some cross-jurisdictional issues? So I'm living in one province, I'm providing care to a client in another province. What does that mean from when providing it remotely? Add to that the complicated landscape that I spoke of for counselors and psychotherapists in particular. You could be practicing or living in one province that's regulated, providing service unregulated, vice versa. So looking at all of these factors, what types of presenting issues, what types of situations are dealt better with from a virtual perspective versus in person. I think we still have much to learn when it comes to virtual care. And so I think I'll leave it at that. Thank you so much again for the opportunity to be here today, and I will pass it back to Ivy.
Thanks so much, Kim. And I'm going to pass over to our next commentator, Gord Garner, who is Vice President at the Community Addictions Peer Support Association. Please go ahead, Gord.
Thanks, Ivy. And so I just want to start off by recognizing the interesting nature of the work that was done in this task force. The idea that, trying to find everybody that's involved in this work and then realizing you couldn't find a whole bunch of people and what that means, and so there's a blank spot there. I think what was it described as a cave, an abyss or something. And so our society sort of set up to work with numbers and work with data. And then how do you work with no data? And how do you make that one of the most significant parts of this report? That there's a whole field of people working out there that we can't find, can't track, can't report, can't support, can't find out their experience as maybe the most significant thing that's going on here. There's another healthcare profession in Canada where you couldn't find much data. I guess the other thing that I note there is that the health profession is kind of noted for reporting doing well. And so, when you see people having higher resilience sometimes, and that can be the price of the job sometimes, the idea that I'm okay and I can help you then can sometimes create suffering for people. So those are a couple of things that come to mind. I think it's really important to tease out in the future what peer support workers we're connecting with. I would suspect that most of the peer support workers we're connecting with are mental health peer support workers because they're the visible ones. That we know that because of the higher level of stigma associated with substance use issues, that those peer support workers tend to work below the scene. So another source of mystery there. Then the idea, to my mind, is that the two-tier, we really need to have this combination of public and private healthcare be seamless to people, so that even as we celebrate the success of online, and even as we celebrate the success of increased insured activities, we're also recognizing that we're leaving other people further behind. And so we don't want that to happen. And we don't necessarily want to overburden the system with costs, but certainly we want anyone who's struggling with their mental health or their substance use health to be able to access fair and equitable care in the manner in which they need it, at the time in which they need it. And part of what I see sometimes is an alternative care system being developed where, those folks can help themselves. They're best off helping each other. And so we want to make sure that peer support isn't that peer support is recognized as an important part of health, an important part of community. But it's not supposed to be a second level of care for people that this main system doesn't want to take care of. It's not supposed to be cheap labor. So all that sort of stuff comes to mind. I guess I don't have a lot to say other than thanks, but I do want to know one really important thing is that mental health has been inequitably funded forever. Substance use health is funded through an addictions lens, not through a substance use health lens. So you can imagine the inequity involved with that. We just had a pandemic in Canada, continuing to go through that, which means every child in Canada experienced an additional adverse childhood experience to those that they may have already been doing. And we know that for every childhood adverse experience, it is a multiplier to physical, mental health, and substance use health throughout the lifetime. So we truly have a pandemic coming. The other thing that's happened, as you can see by the reports from MHCC and CCSA, and the Canadian adults have modeled coping skills for those children. And those coping skills they're using is increased alcohol use and increased cannabis use. We are setting the stage for a population that is going to struggle with substance use health and mental health going forward. And if we don't prepare our workforce for that, and if we don't create systems of care that are reportable, and we don't create mechanisms and measurements for success, we're going to have quite a mess on our hands health-wise. Thanks.
Thank you so much, Gord, raising really, really important issues. And we do encourage everybody to put comments and questions in the chat. We are going to move now to Bonnie Wong, Executive Director of Hong Fook Mental Health Association. Please go ahead, Bonnie.
Thank you very much, Ivy. And I have a lot to echo on Kim and God's comments. Basically, because I'm coming from a very grassroots community-based organizations, as an employer, I always ask a question to myself. I think this survey actually provides a lot of good food of thoughts. How do we continue to run a mentally healthy organization? This is going to be a challenge, knowing that there are a lot of difficulties in recruitment and retention of talents. And especially knowing that the population we are serving, their needs are not just, one particular type, it's multiple. And we believe in the holistic healthcare approach. That means it's very client-centric. A lot of evidence-based, standardized intervention models may work for majority of the people, but not all. So I can continue to see the challenges of inequity across the nation, and the inequity continue to grow. We know that traditionally there are a lot of challenges even before pandemic, is under resources or underfunded in many public funded organizations. So how can we attract more people to join this field as a healthcare provider, and then supporting them to receive that regulated profession? We continue to see there are passionate people there, they want to help, but burnout rate has been rising, and staff turnover is unavoidable. And also the market in the surface market very competitive now because of the funding. It can be like it's not as attractive maybe in the private sector in terms of the compensation or some flexibility. And knowing that the type of clients may slightly be different in terms of people are able to pay from their own pocket, or the people they are actually have very diverse and complex social determinants of health issues. So when we are planning for the nation, how we can have a healthy workforce, and also how we can support clients to have equitable access for services. I think those are key questions I always keep in mind. And understanding the intervention in terms of the variety of approaches, how it can be respected, and how we can work collaboratively with just paid professions or informal caregivers, peer support workers, and how we can support that volunteers in the healthcare system. I think this part hasn't been thoroughly explored, but I think they play a very key role. And then I have questions about how we are dealing with the data issues. I think God and Kim also identify. I think if we are not consistently collected, this demographic service utilization, and a lot more racial or cultural or language specific information, I think we are continuing to marginalize the population's needs, and for those who are much more vulnerable in whatever ways, either they live in urban environment, suburban or rural environment. And then we need to address the unfairness in compensation across the workforce. Based on, is it just the regulated professionals, they will have that particular pay, or we will look at certain committees, they may not have regulated professional supply in supporting their cultural or language community. How do we help those in order to facilitate that equitable access for essential services? I think those needs to be more narrowly focused and look at, the reality, resources allocation and support. And one thing that as an employer, I find is always continuous challenging is the funding formula is always very focused on the front line, maybe just the providers, but there's so lack of investment in the management and administrative sector as a backbone to support the frontline, sector. And for cultural or racialized public funded organizations, we are noticing that we are getting thinner and thinner because of we have many programs to manage, but many reports to deal, but we are lacking of resources. And so I'm hoping that needs to be, addressed. And then the other things we are noticing is on top of our, treatment to support people struggling with mental health and addictions, how can we do more work in terms of building resilience, both for clients and as well with providers? I think Kim has highlighted a very good point of the concept of self-care. I think in reality is not only individual self-care, it's group support are equally important because I think the staff mostly now is really missing the social interactions among peers. And the social connectedness is really important. And so the support for in-person connection needs to properly, recognize and support them. And also is access to information and resources. Because of stigma, and there has been a lot of sometimes even professional opportunities, training, and talk about mental health in workplace may not be very attractive to certain staff, that they think that I'm immune with mental health challenges, and the stigma and the lack of the knowledge in many workforces. How do we be creative and to support the workforce to engage in the dialogue of mental health and well-being, and resources and support, and maybe some online learning and training, which may not need to be self-identified. Maybe some of those opportunities need to invest to build those resources and support. So I think I can continue, but I know that there may be people will have a lot of questions, then we can have more conversation. But in general, I really value this opportunity for having this conversation as look into the structural and systemic, challenges, and how we can work together to make a difference.
Absolutely. Thank you so much, Bonnie. Really, really important points. And I know that we could have a very long discussion about this. This is so rich. And but I do want to give an opportunity for anybody to pose a question. We're a sort of a medium-sized group that we can still allow that. So if you would like to post in the chat that you would like to ask a question, or you could post the question into the chat, I'm happy to unmute you so that you can post that. But I'm also happy to have Kim or Gord or Mary or Yelena provide any comments, and you might have some questions amongst each other as we're waiting for someone to post a question, open and add that. We have lots of thanks in the chat for a very informative session. So thank you for that, for sure. And some people did ask about the slides. The webinar will be posted in its entirety. We'll edit some things out, put an intro and an outro, and we'll have that up on our website as soon as we can. Keep it in mind, we're a volunteer organization. All right, you guys must have, finished all of the sentences, addressed all of the issues. I'm just going to go back to Mary, if you have any closing comments that you would like to make.
Thanks, Ivy, and thank you so much, Kim, Gord, and Bonnie. Your reflections were just so rich, and yeah, again, it's just, I think there's so many diverse perspectives. I mean, we have this umbrella mental health and substance use workforce, but of course, within that, there's so many different ways that people are contributing, and there are so many unique policy issues for different parts of the workforces that were part of this study. So really appreciated the different perspectives that were brought in through your panel. And yeah, that's it for me.
So we do have a question, and it's kind of like, what would be your elevator pitch for the new Minister of Mental Health and Addictions? And so maybe I'll first of all ask our panelists. Kim, what would you say to the new minister, or what would you request?
Oh, wow, that's a big question. I think if I had to choose one, I would say mental health parity with mental health and physical health care in Canada.
Excellent. Gord, what would be your wish list? Your elevator.
Don't use the measuring stick of the past to know what we need for the future. Just find out what we need and do that.
Yeah, very, very good point. Bonnie, what would you say to our new minister? Oh, and you're on mute.
I think it's important to recognize the workforce capacity crisis.
Absolutely. Absolutely. We don't even know what we don't know, but absolutely. Thank you so, so much. And with that, and other people have put comments about what you would ask the new minister for, thank you. Please feel free as you're leaving today, leave some notes for us in terms of how we're going to go forward. So I'm going to bring us to a close. You have a minute and a bit for the rest of your lives. And I want to thank so much Mary and Yelena, Kim and Bonnie and Gord. Thank you again. And thank you all for joining and participating. Really appreciate it.